watch or you listen in or watch and share this interview with us would be great. Let people know as well. Start this off. It's all about the health care system. Taifa, not sure it cares. SHA, the situation we find ourselves in when it comes to the hospitals who decided, listen, money's not coming in and we are not going to take this anymore. We are not serving. Forget Miguna not boarding. They're not boarding this flight at all. They're saying, nope, this ends here. Is there any development? We spoke to Thuraniri, who I couldn't manage to get a hold of. Yes, and he shared his thoughts. He was very clear that the system is working and the money is being paid. But we didn't get the other side of that story, the second part side of the coin, Felaris, and we get a chance to do that this morning.
Yes, we get a chance to sit down with none other than the founding chair of Rupa. Yes, we've seen that name being mentioned on the news for the last couple of days, few days. Chico hates it when I use the last couple of days, so I'm going to say the last few days.
Few days, yes.
Yeah, because we are here to just help make sense of the numbers and why services are not being lent to you under the SHA, Taifa Care, whatever it is that we want to call it at this point. I'm so confused. And we're joined in studio by Brian Lishenga, who's the Rural and Urban Private Hospitals Association founding chair, like I mentioned earlier. And we're going to be having a conversation really squarely around what's going on with this health scheme of ours. Karibu sana, Brian, to Capital FM.
Yeah, thank you so much for having me. It's a pleasure. It's my first time.
Oh, it is.
Never been here.
Okay, you're first. Great. Well, that's we will try and be very kind, patient, slow, and gentle. But you're used to the pressure. It's not your first time on media. Let's just start off with there have been recent discussions. In fact, the last time we were having a conversation about this situation, we were speaking to someone who is part of the whole debate, Thuraniri, and he was pointing out that the government is making progress in payment. In fact, broke down that the money being claimed owed has already been paid, so much of it from the 30 billion we were down to 10, was it?
9.
On the morning of the 27th of February.
Well, Thuranira is my friend, actually. He was maybe 2 years behind me at School of Medicine, so I know when he's lying. He's not being entirely factual. The reality of the matter is that we first of all, do not know the entire debt value. We do not know the entire debt value. We have estimates, okay? We have estimates. So I'll give you, I'll try my best to give you the true picture.
Yes, please.
And this is based on the records that NHIF, the Transition Committee, and SHA, and this is in the public domain. So, last year, September 30th, that's the day before we transitioned to SHA, the total liabilities that are in what we call verified claims, which do not have any contest. These are liabilities where providers, whether public, faith-based, or private, and the NHIF agreed that these are clean, verifiable liabilities were payable, were 19 billion. 19 billion Kenya shillings. There was an attempt by the Social Health Authority to pay using monies that were carried over from the NHIF. And these payments, by the way, and I would like people to understand that the transition began on 22nd of November 2023 and continued all the way to the 21st of November 2024. During that entire period, 23 to 24, that was transition. And during that time, we were paying debt using NHIF, not SHA. Now, what NHIF paid, or rather SHA paid using NHIF money, and this is in public statement, the Cabinet Secretary mentioned it yesterday in the Senate, was 8.6 billion, okay, out of the verified 19 billion. So if you do simple math, you see that you have an outstanding of verified of 10.4 billion. But that's half the story. The other half of the story is that when SHA took over, there were claims which were in transition, because claims go through various verification stages before they are determined to be payable. So the claims in transition were something like 2.7 million claims. Now, for context, we did a study a few years back, and we found out that the average NHIF claim then was 15,000 shillings. So I'm just trying to paint a picture here, because these are claims that were still in transition. So if you do simple math, 2.7 million claims times 15,000 shillings, you end up with a figure of 40 billion Kenya shillings. These were claims which were in transition. Now, just to paint to you the fact that these claims have been moving from unverified to verified. Yesterday, when the cabinet secretary spoke before Senate, remember, when they paid last year, they ended up at 10.4 billion. Okay. Yesterday, she said that debt now is 24 billion. So how did it move from, if there was no NHIF, how did it move from 10.4 billion to 24 billion in February this year? The reason it moved is because as they verify, 14 billion more of worth of claims have moved from unverified to verified, and we still have a bunch that is still coming in. Our estimate is that when all the tabulation is done, you're going to end up with somewhere around 30 billion Kenya shillings. So these are facts and figures that the government is fully aware of. So this is what I'm saying when my colleagues on the other side say, we are paying, they're only telling half the story. And part of the reason why there is so much panic around this, we believe, is they are looking at what the arrears from NHIF are, and they are panicking.
Let me ask, because I know under SHIF, the time frame that's been stipulated is 30 days for claims to be sorted, correct? Under NHIF, was it still the same?
No. So just to clarify this one, boy, is that the contractual time period is 90 days, even under SHIF.
Under SHIF, okay.
What's happened, and what our colleagues are really trumpeting, is the fact that they are paying faster than 90 days. It's fantastic. I mean...
that's something he highlighted.
We celebrate this, but we always tell them that, why do you keep patting yourself on the shoulder when you do the right thing? This is what you are expected to do. It's sort of like, wait for us to do it after 90 days. Why? Who wants to do that? The contractual period says, it doesn't say at the 90th day. It says within 90 days. So if you pay on day 64, why should I give you flowers? I mean, you're just simply, acting as per contract.
Correct.
Even then, that being as it is, we still do appreciate that NHIF used to have significant delays beyond 90 days, and that SHA is trying to make sure they pay within 90 days. The issue is this. The issue is this. We keep being taken back to how fast SHA is paying every time we ask for NHIF money.
Correct.
This is sidetracking. I explained it this way. It's like somebody, let me use a local duka example, or just use a local shop example for which people can relate to. So there are guys who may have an area canteen, or so you go there in the evening and say, okay, give me milk and bread. So this guy knows you live here, so they have no problem. They give you milk and bread, and there is a book they write. Brian took milk and bread today. He went. So I do this. The agreement is that you're gonna settle this at the end of the month.
Yeah.
Then when the month comes, say, this month was a pretty tough month, so let's just keep going. So me, I've been paying. So the Duka guy in good faith says, fine, since you still live here, anyway, let's continue. Then 3 months later, that Duka guy says, enough. It looks like you're not going to pay this debt.
Yeah.
So then when you come, he says, no more credit. And now what you tell him? Tell him, I've gotten a new job. I've gotten a new job. Things are better. So from today, I'm going to be paying you regularly. If we just forget that 3 months credit I extended to you. This new job is so super.
Yeah.
I assure you, from now on, I'm going to start paying you on time, you know. And when you push a little further, you know what he says you. By the way, the milk you gave me 2 months ago, it was actually stale. This is the kind of game we are involved in.
I see. And the tussle between, government and the reality coming from your body, and the reality we keep hearing from the PS of Health, from the CS of Health, and the chief SHA chairperson, there's a disconnect. And to any ordinary Kenyan, the sentiment comes down to, am I able to access services? Should I go to a hospital and use SHA without even getting into the politics of it? And I know right now, it's been how many days since services stopped being given?
Days.
It's been 5 days. How do we get to the end of this deadlock?
It's very simple. When you go to hospital and we see these testimonies from patients that I had a bill of 300,000 SHA paid for me. We don't dispute that these testimonies exist. But what we would like Kenyans to understand is that when you say I went to hospital and my bill was approved by SHA, you should not be celebrating SHA. You should be celebrating that hospital for extending you credit. All right, that is the reality of the matter. The people need to understand that.
So hold up, let me hear this. Let me hear this correctly. So it's not SHA that we should be celebrating. They paid. We should be looking at the hospitals and saying the facility is extending credit to SHA. They're not receiving any money.
They are not receiving any money. At the point where you got service, there was no transaction. There is nothing that hit the account. You simply walked into that hospital, used their facilities, their nurses smiled at you, the doctors did the surgery, the waiters waited on you and brought you food. All that was done for free by the hospital.
So the hospital was gracious enough
to
lend you this service because there's nothing in it for them. Which takes me back to, at the point we were rolling out SHA, because I know all stakeholders were involved in terms of consultations, this, that. I'd want to actually hear from you, Brian. For us to get to this point, there must have been these, the hospitals and the facilities knew how much backlog there was in terms of payments from NHIF, even by the time we are coming in to transition to this. And you did paint us a picture where this transition started from 2022, you said.
2023.
Were there alarm bells screaming and being signaled from your body that we would get to this kind of situation because we're in a sticky mess?
And we were screaming very loud. We were just not being listened to. So, for instance, I'll give you an example. Proxy means testing. This is what they use now to determine premiums for Kenyans, and really explains part of the reason why you've registered 20 million Kenyans. You registered 20 million Kenyans, and only 3 million are contributing. We whistle blew on this. We raised red flag on this mechanism 2 years ago. We told them, because we saw it early, they said, we asked them, how exactly does this work? And they said, we will have 18 parameters. We will check whether you have piped water, you have tiles in your house, whether you have electricity, whether you own a border or you own an SUV.
If you have Wi-Fi.
How many children you have, how many go to which school. So we asked if you have a mobile phone. And we told them, first of all, just basically, do you expect Kenyans to tell you the truth on this one? Like once people figure out that if I say I have Wi-Fi, my premium goes up. People are going to game the system. So from the perspective of it is not possible to deploy it. The other thing we told them is that for Kenya has an estimated 14 million households. So the average household is around 4 people. So it's around 14 million households. So we said your means testing, for it to be accurate, you have to deploy it at 14 million households. You have to have an enterprise the size of IEBC and a budget that side for you to actually do this. We told them this, and they dismissed it. They said, no, we have some data from Kenya National Bureau of Statistics. We will extrapolate. Now, the extrapolation resulted in this. It resulted in the fact that most Kenyans don't think their premiums match their standard of living. That is number one. Correct. Number two, so because of that, because Kenyans now are used to paying 500 bob, and this is a guy whom you are using a computation to say pay 1,200 per month, which you have to pay 1 year in advance, guys are dropping off. So, and these are things we told them 2 years ago. Now, I think that when you're having these intellectual discussions in those air-conditioned boardrooms, people sometimes just get over their heads, and they want to show their education is very good. They know these things. We told them practically this cannot be done. And in fact, the Kenya Medical Association, for instance, was very clear that a method which forces people to contribute in a country with 60% unemployment is never going to work. You see, if we have more people in the formal sector who have salaries and jobs, then you can have a contributory scheme because you have a way of tracking them. Let me give you a very good case in point. KRA has one of the most robust systems for tracking anyone, anywhere. But they still have never been able to succeed to collect enough taxes.
Correct.
If KRA had a system that was working, SHA could have simply said, hey KRA, we see you guys are able to catch the informal sector very well. Why don't we borrow from you?
Yeah.
But even KRA has struggled. So KMA, for instance, said very clearly that we should go for a general taxation system. Let me give you an example. What would have been the problem in having, let's say, a 0.5% increase on VAT and then ring fence that fund and just say this 0.5% on VAT is specifically for financing healthcare.
Yeah.
Do you know why that would have been beautiful? If I am blessed and I can buy a shoe for 7,000, I would contribute more because my VAT is higher. Now, the other person who can only afford maybe something for less than 500 would contribute a little bit because that's what
they're able to afford.
But overall, all of us would have contributed. So it is not for the lack of wonderful ideas that we are in this mess. I think part of it was Kenya became a testing lab for ideas. Guys had these concepts that we can try, and now we are the testing lab, and some of these are not working.
We are trying and experimenting with people's lives, and that's the most unfortunate thing. And what I'm hearing here is an idea that was not fully fleshed out, and a lot of contributing minds brought to the table was rolled out for the sake of a few people that are looking to establish legacies. And there was no problem with NHIF. Yes, it could have done with a few fixes here and there, but it's a system that had taken shape and had been working by the time we're bringing in Chief SHA.
Absolutely.
A lot of questions, of course, continue coming in, and if you're listening to us and you're watching us on the live stream and you have contributions to this conversation, 0701984984 is where you can reach us. That's our WhatsApp line, or at 984 in the morning using the hashtag DriveIn over at X. Chico?
Absolutely. We're speaking to Brian Lishenga, and I just got a message from Thuraniri, who might be joining us a bit later on, seeing as, you did mention him and bring him up. So he said he might be joining us a bit later on. But one of the things you brought up, so there was, of course, let me see if I could get to the top of this, response to the parliamentary questions from the Ministry of Health, Office of the Cabinet Secretary. They were responding to some of the questions were asked, and one of which you've talked about with regard to the government's efforts to streamline the process and ensure timely payments. It reads, A, the ministry has formally engaged the National Treasury to facilitate the prompt and adequate release of funds to support seamless operations. B, the ministry is working closely with stakeholders to establish a clear pre-agreed framework, and that's where my attention is caught, pre-agreed framework for the posting of interns and the modalities of their engagements, ensuring efficiency and predictability in the process. And that's something we're going to get into in terms of the interns and the doctors and the hospitals themselves. What do you make of that response?
I think we had a meeting with the Principal Secretary on Monday just regarding this impasse we have. And one of the things that kept coming back over and over again was the government does not have money. And this goes back to the fact that they acknowledge that these liabilities are legitimate, but then they say we can't pay, and this is going to spill over also to the interns, and all this. So and even the clinical officers. So we have a sector that is grossly underfunded. Even that pre-agreed framework that you're mentioning is contingent on the availability of resources. If there is no resources, doesn't matter how beautiful a framework was written, you have to put money on the table. Yeah. So we have a situation where half of the funding to the Ministry of Health has gone because USAID is pulled out. There's no donor funding, and people need to understand this, that when you see the Minister for Finance read a budget and they say 152 billion shillings allocated to Ministry of Health, if you follow the paper trail, 75 billion out of that was coming from donors now, which means that as a nation, our funding to Ministry of Health is literally 75 billion in a budget of 4 trillion. You know, this
shows you where the priorities are.
You know, we have a 4 trillion budget, and we give 75 billion shillings to health. Doesn't that explain why we are in this bind?
Oh,
you know,
it does.
you can understand. You can look at it. So as long as we do not address, look, this is our country. We cannot expect neighbors to fund this country
True.
for us.
Yeah.
We have to fund this. When our colleagues say SHA is working, I always correct them and tell them it's not SHA working, it's NHIF working, and they always don't understand what I mean. Okay,
I like that. Can I just interrupt you
Yeah.
for a second, because I want you to explain that, but I want to read something
Yes,
else that just
sure.
caught my attention. One of the questions asked, how much money in terms of contributions was in the accounts of the National Health Insurance Fund, the NHIF, at the time of transition to the Social Health Insurance Fund, SHIF? And could the Cabinet Secretary, the banks and the bank accounts in which, state the banks and bank accounts in which the money was held?
Yeah.
He did exactly that.
yeah.
We have a list of, in terms of collection accounts, it's KCB with 60 million. October contributions, the balance, October contributions being 1.4 billion. And NBK had a balance of 16. You go down that list, Co-op, Equity, NCBA, all the banks mentioned, and then you have 1.3 billion. October contributions coming to 2.9 billion. And you go to settlement accounts. They had 49 million, just under 50 million. You go into operations account. They had a balance of 118 million. Ultimately, all added together was 1.4 billion, just under 1.5 billion shillings
So this is the money that was in the NHIF accounts
going into SHIF.
into SHIF, and so I mean, so there's a problem in there because contributions were also falling because people were uncertain, because NHIF at its best used to do 7 billion shillings a month when it was really working. Used to do about 7 billion. So when you see them talking about around 1.4 billion, just tells you that Kenyans had really dropped off in terms of contributions. And what is interesting to us that even now, SHIF, or rather SHA, is not yet at the level where NHIF was at its best, despite the fact that we are paying more. You know, so SHA. So the report was that SHA over the last 4 months has raised 20 point something billion shillings, which tells you that they are averaging about 5 point something billion. They are doing much less than NHIF was doing at its best. In its best year around 2021. 2020-2021, NHIF did almost 84 billion. So you back to what you mentioned about whether should we have just tweaked NHIF. NHIF was getting to a place where public confidence was rising, and people were certainly sure that this thing works for us. You had people in the villages who, you know, old women who would get so stressed if the 9th of the month came and for some reason they forgot to pay their 500 bob. You know, they would be calling their kids, are like, I just forgot this, please make sure I sort this out. And you want a country to get to that kind of point where you do not have to cajole and convince and beg and plead, please
and
pay gaslight. You know, when things are working, nobody will need any convincing.
Correct.
Certainly there are those who argue that when you know, people like Brian go to radio stations and they say these things, we are making people less confident in it. No, our point has always been, and why we speak out about these things, is since we are at the service provider end, Kenyans are not getting value for money. So we are voicing the fact that when you promised us something, this is not what we are experiencing. And actually, we see our role as trying to help them. We are trying to tell them, hey, the reason why guys are not paying is because services are unavailable. This is what we are trying to tell them. And we want them to be humble enough to understand that we are frontline workers. When we tell them value is not being given, they can correct.
Correct.
I just want to jump in here because we're about to delve into the sports news and quickly come back. But speaking of SHA, it's SHA who sent a message via 0701 984 984, but not the SHA, the authority. But SHA, the person, Sawan Shah, has a very interesting comment. He says, "Hi, Capital, listening to Brian Lishenga on Capital FM. As a hospital owner, I can attest to the fact that he is spot on that NHIF arrears have brought hospitals to their knees, particularly level 2 and level 3 hospitals, which form the bedrock of healthcare in this country. So there's also an inequality in payments of NHIF arrears. And then the question comes in, can you also elaborate about how primary healthcare, which level 2 and 3 hospitals work under, is being funded under this broken SHA model? For the benefit of listeners. Regards, Sawan Shah Jacaranda Maternity Hospital. We will come back to that question because I want you to delve into that one. It is something that Thuraniri, who you've mentioned, touched on and said this is not necessarily the case and that something would happen very quickly. A solution would be made. We asked if that discussion came up and if we do have a solution. Brian Lishenga, Rural and Urban Private Hospital Association founding chairman right here on Capital in the morning. We'll be back to answer that question from Shah, about Shah, and any other question that you feel like throwing our way via X at 94 info, hashtag drive in, or via WhatsApp, like Shah did, 0701
It's not just a
What's up,
blog.
y'all? I'm Beyonce.
It's the art of living. Capital Lifestyle, where every story is a front row seat to the extraordinary. We don't follow trends. We set them, from the glimmer of couture runways to the glow of candlelit dinners, from the thrill of fairway destinations to moments that turn ordinary into unforgettable. This is life elevated. Your next adventure, your next indulgence, your next inspiration starts here. Find us at capitalfm.co.ke/lifestyle. Connect with us at lifestyle@capitalfm.co.ke and follow the journey with Kenya's undisputed premier lifestyle connoisseur, Video. On socials at Captain Video. Capital Lifestyle. Not just life, the best of it.
2025 is the year you level up. 2025 is the year you make boss moves. Enough with a vision board. Shift gears and make your dreams come true with the KCB savings account. Is the account really worthwhile? Well, tune in daily from 3 p.m. to 7 p.m. to learn more about the KCB Deposit and Win with KCB Gold Savings Account on the Jam. Join the winning team and change your life with the KCB savings account. The more you deposit, the more your chances of winning. Terms and conditions apply. Deposit and win big on your KCB Gold account thanks to KCB Bank. For people, for better.
Hashtag appoint IEBC now. Capital Sports Update, where sports is taken seriously.
Lillian Award was the heroine as Arabic starlets beat Tunisia by a solitary goal in the second leg of their Women's Africa Cup of Nations qualifier, which was last evening. The Romania-based goalkeeper saved 2 penalties after Teresa Ngesha had struck early in the first half, giving Kenya the lead. Starlets will now be facing Gambia in October this year. A chance to qualify for next year's continental competition. Elsewhere, the much-hyped Mashemeji Derby, the one you've been expecting, FC Leopards up against Gor Mahia, earlier scheduled for this Sunday, will not happen. It's been postponed until a later date. You know how it happens. Leopards, who were to host the match, said in a statement that the postponement has been necessitated by the country match was over. Considering what we're dealing with in this country, if you sit remaining silent, then you are part of the problem, endorsing the situation which we find ourselves in. That's why in studio on Captain in the Morning with Philarius and myself, Chico, we have Brian Lishenga, Rural and Urban Private Hospitals Associations, aka RUPA, founding chairman. And I think we'll come back with you straight into this question that was asked by Sawan Shah when he said, can you elaborate about how primary health care, which level 2 and 3 hospitals work under? Remember, he pointed out how these are the bedrock of healthcare. Those work under this primary health care. How is it being funded under this broken SHA model for the benefit of the listeners? I'd love to learn that as well.
Okay, so just to paint a picture, 91% of hospitals in Kenya are level 2 and level 3.
What?
91% of hospitals in Kenya are level 2 and level 3. So just to explain, when I saw a statement yesterday out that, SHA has 8,600 contracted hospitals, and therefore, if 600 hospitals under RUFA go on strike, what the hell? We have 8,000 more hospitals to keep going. I just want to correct the impression here. It's this 91% of 8,600 is 7,400 hospitals are level 2 and level 3. Therefore, that leaves you with just about 1,200 hospitals. Half of those are RUFA members. The rest half are public members, public facilities. Now, these 7,400 hospitals have not been paid a cent since November 2024. A cent. So even if we... And I would dare anyone who from SHA to come and say we've paid them. They have paid them nothing since November. In fact, the few who were paid in November were those ones who were already previously contracted by NHIF. All new level 2 and level 3 facilities contracted under SHA have never been paid a cent since October. Now, these are the same hospitals where we are being told, you are telling Kenyans, healthcare is free, go there. How you go there when you have not paid them? So literally primary healthcare, which is 91% of healthcare facilities in Kenya, is non-existent. And this is why poll after poll after poll, when you ask Kenyans about popularity of SHA, it keeps tanking. Because if it's a proper poll and you're asking it in the villages, they will tell you that when I go to my outpatient facility, either it does not have supplies, 2, that outpatient facility has not been paid for a very long time.
Correct.
So how did we end up in this situation? We ended up in this situation because there was a very clever model. Back to cleverness. There was a very clever model that was proposed called global budget capitation. Okay, guys, this is these things even health sector guys don't understand them. And then there was the idea of primary care networks, and then there was the idea of disease weighting. So all these fancy things. You know what used to happen under NHIF? Under NHIF, you'd simply be told, hey, you are a beneficiary, choose a hospital which you prefer to go to. So you choose a hospital, and then that hospital gets paid a fixed amount of money to offer you care. How they do it is the business of the hospital. It was very simple. But now, because we have come up with a very clever, Einstein level formula, which we can't also figure out as a country, hospitals have not been funded. So we have a situation where primary health care is stuck in this country. And remember, 91% of facilities in Kenya are this one. So even if you did a survey today on hospitals, unless you disaggregate, if you ask hospitals, are you being paid or not? If 91% of hospitals tell you no, what do you think that survey will show? It will show you that nobody is being paid. So you're only paying 9% of hospitals irregularly, 90, and then you want to trumpet that and say, hey, we are paying, because you are paying 9%. Okay? And then these 91% of guys who are in limbo, never received a penny, serve the vast majority of Kenyans, are the reason why SHA is not taking off. And unless we fix that problem, it doesn't matter how much you say you have been paying.
Here's an interesting one.
We're
joined by, just via my personal call, Dr. Dhuraniri, who you said also went to school with him as well. I know you've been listening in onto the conversation, and just a quick recap, it is all about payment, in which Shanghai's Brian is very clear that this is not happening. Do not hear anyone saying it is. And when the payments are being done within a 90-day period, instead of beating your trumpet about that, it's something that's required. You should be actually looking at the level 2 and level 3 hospitals, which are complaining, which are the bedrock of this 91 as a percent of the hospitals there. What are your thoughts on or your stance on the payment issue first and foremost?
Thank you, Chico, and thank you for hosting my senior. Dr. Lishanga is somebody I really respect. He's my senior and I know him very well. So first things first, I think this discussion would need to host me and him so that we sit down there. And I never got a chance to listen to the whole interview since when it started. But for now, I can respond to a few things that you say. So on the issue of payments. So first, I always ask myself, how did we find ourselves here to find ourselves in a place whereby we owe public facilities in excess of, my facts are 10 billion shillings. Lishanga's facts are 30 billion shillings. So it's up to him to reconcile himself to what is the actual fact of the amount of money that is owed. So basically, if the NHIF system was really working, we would not find ourselves at the point of transition. We owe facilities 19 billion. So what has happened from 1st of October? Between 1st of October and December 31st, by the time the year ended, the government endeavored to pay part of the old verified claims to the tune of 8.6 billion. So what is remaining? What is remaining is 10 billion. What is above that is some of the money for work injury benefits and the last expense has not been paid, which it's to individual clients, or patients, people who have gotten injuries at their workplaces. So also that amount of money is pending. So as government acknowledges, But the truth of the fact is that between October and December, there's some money that was paid. As you all understand, money has to be appropriated through National Assembly. So the money has to be passed through National Assembly, then it's appropriated to the relevant ministries for payment. Part of that money is owed within government MDAs, and we're in the process of budget making. I remember, Chico, when you called me earlier, it's the same thing I explained, that we're in the process of appropriating much more money to continue progressively paying this debt. Have this debt been acknowledged by government? Yes, government has acknowledged it. To the extent that yesterday during the Senate proceedings, when the Cabinet Secretary and the Principal Secretaries appeared in person, a comprehensive report that Chico have shared with you was tabled in the Senate of the amount of debt, how payment has been done. Now let's talk about primary health care. When we transition, previously what used to happen is that capitation money used to be paid to facilities to offer services. And the money used to be released quarterly. 1st October comes, we decide, using the old data and what was going on, because we are transitioning, capitation money up to 1.3 billion shillings was paid. 436 million to government hospitals. The rest of the balance, in excess of 800 million, was paid to private and faith-based facilities. Part of the facilities had not fully onboarded, because you are required to onboard into the new system, and onboarding is signing a contract that you agree to the terms of service of government that is offering you for you to sign up into the model. So it took a long time, some of them, to interrogate them, the process and agree to sign the contract, which is understandable. Consultations have to happen. So contracts were signed, manual contracts. Facilities are endeavoring to sign e-contract, because that's what is provided for in the law. We come to January. We decide now, because of what the challenges that we have faced previously, whereby clients' money for capitation was paid to facilities. Part of these facilities were not offering the service, and that money would just go unused, and the facility would benefit from that. Other facilities would overspend, and that money was not be enough. How do we do it? We understand the amount of money that is required for capitation, because it's capitation per person per year. What do? We empower all these facilities to have the portal for uploading their claims. So they continue serving the clients. They upload their claims. So based on the services they have offered, money is released. On Tuesday or Monday this week, there was a meeting with RUFA, which Dr. Lishenga attended with the Principal Secretary Medical Services, Mr. Harry Kimtai. And that long discussion was had, and we agreed on the way forward. Part of the way forward was we have a consultative meeting between the providers and the Ministry of Health officials and SHA to explain this model. Once you explain this model, they ask the pros and cons of the model, and I tend to think that meeting is scheduled for today, which is Thursday today. We explain that model, they sit down, they interrogate it. If they are comfortable with the old model of capitation, money is released immediately. If they are comfortable, we go on with the new model. Because we engaged the Council of Governors yesterday at Naivasha, or the chief county executive members of health in Naivasha, we engaged them, they gave us their feedback. We also want to engage all the key stakeholders in this thing so that the money is released, and this should be released routinely every month. So, on the issue of 90 days vis-a-vis 30 days, unfortunately, the facts have to be told. Contracts rate that claim money has to be reimbursed within 90 days of the claim to be verified. It has been a cry from providers that we limit that amount even to be the lowest amount of time upon verification. We have to cap it at 90 days. Currently, the government has endeavored, if there is money in the bank and claims have been verified, money is being paid. Has money been paid? Monies have been paid up to 30th of January. Is there some money that has not been paid? Yes, there are some money that have not been paid. So what claim? Some of those claims are manual verification to confirm that they are not fraudulent or they are fraudulent. Majority of the money to the tune of, and I read this statement, to the tune of 16.97 billion shillings. December to 24th of February. How many payments are these? These are like 10 payments that have been done. And the other claims are being verified. And it does not have to wait. Once the verification process is over, the money is paid. I submit, Chico.
I love that you've pointed that out. First and foremost, within 90 days, absolutely agreed, no problem whatsoever. I did see a few of reactions from Lishenga. First and foremost, at the top, I did mention the amount of money you said was balanced off, how much had been paid, and we were down to about 9 billion. He said, and I quote, "You're lying, you're a friend of his, and he knows when you're lying and you're lying." And then the CS comes out yesterday and actually puts that figure at, you said 24 billion remaining. Verified, as you said, some claims have to be verified, and it seems that as they're being verified, that amount is rising, and their projection is at 30 billion.
The truth is, Chico, as we talk now, there are claims being lodged by hospitals. The fact that claim verification is an ongoing process, it means claims will continue growing. You verify for today, there are Kenyans who are seeking services today, and once they get the service, the claim will be uploaded. So does it mean the claim will stop? It will never reduce, it will keep on growing. What you have to do is that you need to have the most recent claims onboarded so that you pay the old claims and you start verifying the newer claims. As at yesterday, I could see part of the oldest claims that are there are for November, December. We're in February. Once those ones have been verified, we get...
Lishenga is saying we're talking about NHIF, not SHA.
We're talking about NHIF.
Hello, Chico?
Lishenga...
I mean, I think we are making a distinction here. We have not taken any action because of SHA claims payment. I think we are all agreed. And we always agree with you when you say you're settling SHA claims within less than 90 days. We do have some...
Thank you for agreeing, finally.
Turanira, we agree, Doc. We agree. We agree that SHA claims are being settled within 90 days. There might be differences. We did our own data analysis yesterday, and quite a large number of facilities have received payment for their claims for SHA between October and January 31st. That is a fact. And
Thank you
so,
for acknowledging finally.
thank you, Doc. The only place, we have differences on NHIF liabilities and on primary healthcare model. And the reason why we have differences on NHIF liabilities is because when you pay us for SHA money pays for SHA cost of care. We still have pending cost of care running back a few years. That has not been handled. That is a key difference between us. The second one, which I am glad you said that we have an engagement today, is on the issue of primary healthcare. We know that primary healthcare has been crippled across Kenya. I am very hopeful that either today or tomorrow, we as a sector find a way forward and we move on. So I think there is light at the end of the tunnel on primary healthcare. I hope that we agree in the next few days. Where I think that we are actually helping you guys out is when we say that NHIF arrears must be paid. You described a very long process that has to go to budgetary appropriation, parliamentary approval, all these things. That process requires lobbying. And we are standing here on your side. We are lobbying for you because it is very sad for us to wake up every day and see hospitals in newspapers being auctioned. They are not being auctioned because you are not paying SHA. They are being auctioned because they owe banks, they owe pharmaceutical suppliers for many years NHIF liability. And unless we sort out NHIF liabilities, we have said this repeatedly, Daktari, that doesn't matter how well SHA pays. If we don't sort out the historical debt, the sector will continue struggling. So if we agree and align on that, the minimum we want, and we told this to the PS on Monday, that if you don't have even this 10 billion that you agree is uncontested, even if you don't have that, give us a payment plan. Tell us we can pay you 3 billion, 4 billion, 5 billion now and allow us to look for this other money. But to tell us categorically there is no money is unacceptable for the sector. This is where we are.
Chico, can I respond?
Yes.
Thank you. For once, I'm happy, and I would have wished I was in that studio.
You'd have hugged me.
For once, Lishenga has changed his tune and is acknowledging several things against what he has been uttering out there, and I'm happy for that. So, Dr. Lishenga, we admit that there is a debt that has not been paid. We cannot run away from government processes. There is no money that is sitting somewhere just waiting to be. Even if it's reallocation, it has to go through the Parliamentary Committee of Health. It has to go through the National Assembly. It has to be approved, and this money can be availed. So our humble request to the team, number one, thank you for acknowledging there's something that is being done. Thank you for acknowledging SHA debts are being paid. Government acknowledges that there's a bill of like 10 billion shillings that has not been paid by providers, and providers are suffering because of that. We understand that 8.6 billion had been paid within a period of 3 months. As government refused to pay, government has not refused to pay. They have said, give us time, we go through the motions of the process, whatever amount of money is available. And I tend to think as we continue engaging, which we should not be engaging on air, we should be engaging in boardrooms and agreeing.
We're not complaining.
Chico likes this one.
We are mediators.
We shall continue offering services. This relationship between providers, SHA, and government is long-term, not a short-term relationship. You are doing a crucial work in providing services to the Kenyans, which government acknowledges. So only ask is that let us agree and we continue. We are here to build our country, not to destroy our country. This is our country. From whichever point of view you look at it, we are here to serve the Kenyan. Thank you, Chico. I submit.
Thank you very much. That's Dr. Dhuraniri, and we've been speaking to Brian Lishenga as well, who is the founding chairman of RUPA, Rural and Urban Private Hospital Association. I know it's a conversation that, as he's pointed out, it's a long-term conversation, but your concern, he's acknowledged, and he is happy you've acknowledged that something is happening, and the distinction is being made very clear right here on Capital in the Morning. The issue is not the SHA payments. Those are happening. You can beat your chest about that, government, but we are brought to our knees because of the NHIF historic debt, and that is where the problem lies. Shah, thank you very much for sharing your thoughts via WhatsApp, and once again, we just hope the best for the likes of Sawa and Shah, Jacaranda maternity hospitals and other medical institutions that are being brought to their knees and struggling. And we'll keep in touch. We'll call you actually and find out out how that conversation goes today.
Fantastic.
Brian Lishenga, thank you very much for your time. It's Capital in the Morning, time to get to the news.